All right. Good evening, everyone. Thanks for being here. And also thank you, Jacqueline and Jesse, for helping us to organize this meeting. And
We're so excited to have you all join us for a session put on by the ACC California Fit Committee.
my name is Sun Yung Lee. I'm a cardiology fellow first year at St. Joseph Medical Center. I'm interested in clinical cardiology and electrophysiology. And today's session will be very helpful for me to form my, future career goal. Yeah.
And hi, everyone. I'm Alex Malouf. I'm also a first-year cardiology fellow at Scripps, and I'm currently pluripotent, so we will see. Um,
All right. So today's session is all about navigating one of the biggest decisions in cardiology training and choosing your career path and whether you are drawn to general cardiology or procedural subspecialties such as interventional or electrophysiology, or still weighing on your options. The process can feel very exciting and overwhelming at the same time. And we've put together a panel of cardiologists with a diverse career path to share how they found their niche when that clarity came during the training and how they prepared and what factors helped out their decisions and from daily practice, daily basis, and to the future of the field.
Yes, and we'll be diving into practical advice for fellows and how to build our skills early. So we've generated a list of questions that we'll go through, and we'll have each of our panelists kind of answer the question. And closer to the end, we'll open it up for the audience to ask any other questions that you may have. Just a reminder, this session is recorded for others to see later. And if you guys, feel comfortable to turn on your cameras on and join us for the discussion, that would be great. We will now introduce our speakers.
All right. Okay. So now we can start with Dr. Alison Kraka. And if you could introduce yourself, your name and your subspecialty and your institute and your training, that would be really great.
Yeah, hi guys, I'm Allison. I am a non-invasive cardiologist at UCSF. And after general cardiology, I did an extra year of advanced echo training, like mostly focusing on structural echo. So I work in the cath lab with the interventional folks during edge-to-edge repair and valve replacements. Sorry, one second. And I just started on faculty in October, so happy to talk about the transition from fellow to faculty and also clearly parenthood and cardiology. Did I get everything?
Yeah.
Okay.
Everything.
Glad to be here with you guys.
Thank you so much. All right. Dr. Nadia Sheikh, she's a doctor from our institution. If you could introduce yourself, that would be great.
Can you guys hear me?
Yes.
Okay, so I'm Nadia Sheikh. I work with Sun at St. Joseph's Medical Center, that's in Stockton, California. I did my medical school at UMass, residency at Brown, and then my fellowship at Leahy Clinic, which is a mostly surgical hospital outside of Boston. And then I came to St. Joseph's straight out of fellowship, and I do interventional cardiology. And we do where we are particularly, we actually do a lot of general cardiology as well, but I specialized in interventional cardiology.
Right. Thank you, Dr. Sheikh. All right. Dr. Paul Morado, if you could introduce yourself, that would be great.
Yeah, absolutely. I'm Paul Morano. I'm a critical care cardiologist at Cedars-Sinai, and I've been on staff there for almost 2 years now. I did my general fellowship at Cedars and then an extra year in critical care medicine at Cedars as well. And now have this job as a in a CCU and also do some time on echo and clinic and then some clinical research as well.
All right. Thank you.
Thank you. Dr. Jessica Mao, would you like to tell us a little bit about yourself?
Hi, everyone. My name is Jessica. I am a second year EP fellow, 6 weeks away from being done. I did my residency training at Hopkins. I did my general cardiology at Cedars. I was the same year as Dr. Morano, who's surpassed me now. I did an extra T32 research year, and I am now a PGY 9, finishing my second year of EP fellowship. I am moving up to the Northern California Bay Area for my job. I am going to be working at Sutter Alta Bates in Oakland. And so I would also love some advice about transition to attending hood from everyone as well. But um, excited to be here with everyone.
Thank you so much. Dr. Megan Pelter.
Hi, everybody. I'm Megan Pelter. I'm one of the advanced heart failure and transplant cardiologists at Loma Linda. I've been on staff for almost 2 years now, working both in the CCU, working with our surgical team on the post-transplant and post-mechanical support patients, as well as on the outpatient as well. So we have a little bit of a variety. I also, apart from that, I'm the APD for the Heart Failure Fellowship as well. So definitely can talk about all that spectrum. And happy to be here, happy to talk about my experiences.
Thank you all so much. Without further ado, we'll jump right into our first question. So our first question is, when did you realize you'd found your career in general cardiology or subspecialty in your fellowship, and how did you prepare for this? And like, how did you prepare as a fellow and getting into this subspecialty fellowship?
I
Yeah,
think we can
I
go,
can start.
yeah, yeah.
Sure.
Whoever wants to go, please.
Yeah, so I think in residency had an inkling that I liked cardiology and also liked critical care medicine and was sort of figuring out where to apply, and then ultimately loved cardiology and chose to the cardiology fellowship. And then I think in fellowship I sort of also again came into the with sort of wheel of indecisiveness and was loved the cath lab. I thought EP was interesting. Heart failure kind of had the whole spectrum and wasn't sure about if I still liked the critical care side. But ultimately came back to loving the breadth of critical care medicine, merged with cardiology and critical care cardiology as my niche. I'd say that for once I decided on that, I think maybe as a bit unique is that critical care cardiology is sort of a newer kid on the block, and that mentors and even training fellowships are not ubiquitous for it. And so I think that was one thing of seeking out sort of smaller group conferences. Like there's a few critical care cardiology specialty conferences, one including Cal Shock that we've had now for the past 2 years and just happened last week. NYU and Houston each have their own kind of brands of a specialized smaller conference where you get a chance to meet mentors from all over the country. So I think that was a good chance to get to meet people, to get to talk to them about what their job looks like, what their day-to-day looks like, and also build on research and interest in the field. I think that was one thing kind of unique to critical care cardiology was that it wasn't maybe as well trodden as some of the other subspecialties, and so it needed a bit more of finding mentors wherever they are, and then thinking about the best training pathway for you, especially because I think in the past years, kind of what who is in the CCU is very different at different institutions and different geographies, right? So in some places it's general cardiology, heart failure, care cardiology, so it all varies. So I think kind of weighing that into the decision too was important. So I think the big things for me were sort of diving into fellowship and finding what struck my interest the most, and then finding mentors, even if they're not at your institution, but more broadly, I think was an important thing for me.
I can go next. So, I guess for me, it was a little bit of a journey for me when I first started intern year. I told myself I would never do cardiology, and I think that if I'm speaking very bluntly, right, like we all know that there's a lot of bullshit in medicine, and I really loved doing critical care because it felt like it really cut to the meat of what had to be done. It wasn't, okay, let's get a prior authorization, let's get things done in 2 or 3 weeks. It's this patient needs something right now. And I really thought that I wanted to go into critical care. And what was interesting is when I told my boyfriend at the time, he was really shocked and he was like, "Really? Because you're just really angry and hateful during those months." And I realized that the thing about critical care is it's so satisfying, but there is a lot of burnout because you actually have such a high level of mortality. You're doing a lot of almost futile work at times, it feels like, and it really weighs on you emotionally at times. And the thing that's really frustrating about being in the ICU is, you're managing these patients and you're asking other specialties for things that you need, including surgeons or radiologists or IR. And the thing that I realized is that cardiology is such a self-sufficient field that when you went into cardiology, you got to do everything. You got to look at your own imaging, you got to do your own procedures, you got to assess your own patients, you got to make your decisions. And on top of that, when you do interventional cardiology, the vast majority of your critically ill patients, you come in, you say, "I'm going to do this procedure." And then there's, an 80% chance that you're just going to be fine in the morning. And so I think that that was my logic for going into interventional cardiology, is that I take primary responsibility for assessing that patient and then deciding what to do. And then I get to do it and see what happens. And it's just fair to say that the futility is a lot lower than I think it is in general critical care.
I think those were all great points. And I kind of wanted to add to that. And yes, I'm also the type of person that I really need to be in that particular subspecialty to get exposure to it, right? And see what is it like to be a transplant cardiologist? What is it like to be on the mechanical support side, so on and so forth. But I think what also really helped me to determine my pathway is to see all sides of it. Like was mentioned, critical care can sometimes be rather heavy, if you're just doing, critical care back to back, so on and so forth. With heart failure and transplant, you get the outpatient side, and I was lucky enough to be in a transplant clinic as well for my continuity clinic and see all the success stories from that standpoint too. So what I would probably recommend to the fellows, residents, and the students in the audience is to consider early exposure. So don't wait for that last minute elective, your last block of third year, and then finally realize, oh, I actually really loved electrophysiology. But it's too late for that, or, whatever, the echo imaging, so on and so forth. Do it early, and also not just inpatient or outpatient, but like a spectrum of it.
I probably have the worst answer to this question because I decided I was going to be an electrophysiologist as a first year medical student. Um, I I was at UCLA. Dr. Shiv Kumar is like a legend in EP, and he came and gave us a talk. Afterwards, I went up to him and I was like, I don't really know what you do, but I want to do that. How do I do that? And so I actually applied into medicine with the intent of being a cardiologist and going into EP. And I don't think I really knew what EP was until about like a year ago. And so I'm really lucky that this has worked out. But for me, I think I was that person who, like hemming and hawing through all of third year med school saying, do I want to be a surgeon? Do I want to be like a medicine doctor? I want to do all of it. And so for me, I think EP is really one of those specialties where you do get to do those things. Technically, I'm not a surgeon, but somehow putting in a pacemaker makes me less of a surgeon than my med school roommate who's an ophthalmologist and like pushes a button for a laser. So it's okay. Like for me, I think it's a good combination of the medicine because we do medical management of a lot of conditions. We have long-term care with patients. We also do procedures that get us that instant gratification. Um, our procedures are kind of like the whole medical process, start to finish. We have a patient with some unknown fast heart rhythm, and we can diagnose it and we can treat it all the same, short to medium, sometimes long time span. But, in one procedure, we're diagnosing, we're treating, and you do get that gratification. And it's a little bit, we're not saving lives, but that means that I don't have to take call at 1 in the morning. And so I would argue EP is obviously the best field. But for me, I think I'm really lucky it worked out. And I also felt like the EPs were always the nicest cardiologists in the hospital. And so overall, it was, I kind of just like went head first and this is what I was going to do. And I'm really lucky that it did actually mesh with everything that I'm interested in. The other aspect I was interested in is a lot of the device technologies. I was an engineer in college. And so there's a lot of new developments happening, especially in the field of EP. And so that's been very exciting to watch unfold in real time. Um, So this is my very strong plug that everyone should just do EP. But it is something that I agree with Megan. It's something that it's good to get exposure earlier on because I didn't really know what EP was until like after I started. And so again, lucky it worked out, but it's hard, it's one of those more esoteric fields of cardiology, I think.
I will try to give an answer. So I came to Echo kind of like very, okay, okay, I'll be back.
Well, thank you, everyone, for that. It sounds like early exposure, personality, are definitely things that we should keep in mind when looking for landing on our specialty. We'll move on to our second question.
Right. Okay. Thank you, all the speakers, for your great answers, and it will be very, very helpful for us. So, next question would be, how do you like your career, current specialty now? And do you plan to continue working in your same field or change your field in the future? So that'll be question from us.
I'll try to answer now that I have a minute. I'm sorry for all the interruptions. To just quickly answer the last one too, I came to Echo in a very like roundabout way. I actually thought about like CCU, heart failure. I thought about interventional for a minute, and ultimately kind of decided I did not like taking call, to be totally honest. And I loved the sick patients and making them better, but I really hated going in at 2 in the morning. Like I vividly remember as a fellow doing a STEMI at 1:30 and the attending was like, "Isn't this the best thing ever? Like, isn't there nowhere you'd rather be?" And I was like, "Yeah, I'd rather be asleep." Like, I actually don't think there are places I'd rather be. But that was kind of enlightening, right? Because like that is the feeling. Like that was really true for him. And I think what you should feel with what you're doing. So I feel like Echo was a fun balance of like the physiology of medicine and also like I enjoy being in the structural procedures and like helping with that, but not being on call in the middle of the night. And I have currently loved my job. I have a nice balance between like one day in the cath lab, one day in the echo lab, and a couple days of clinic, and um, feels reasonably like balanced and sustainable. So I do plan to continue that. But plug for imaging for anyone. So yeah.
I think to kind of to continue Allison's excellent point is that I would think about yourself like 10, 20 years in the future. When you're 40, when you're 50, are you still going to be excited at 2 a.m. in the morning about that cath? Or are you going to be complaining the entire way over to the, to the cath lab? So I think that is something to really, really consider. Certain portions of cardiology are super cool, but again, look for sustainability as well. And also work-life balance, I think is very important. I love, heart failure transplant. I think it's a fantastic field in that you can go above and beyond, standard therapy. You can continue on to transplant, which is fabulous. You get to give them a whole new lease on life, which really like makes my day every time I go into transplant clinic, or I get to tell a patient that we got a new heart for you. It's time for a new start. And a lot of the times there's tears of joy, tears of happiness, shouting. So that really makes my day and makes it really wonderful. So to answer the question, yes, I really love my specialty and would definitely do it again.
So I'll go next. So I think that, the last two speakers appropriately made the point about lifestyle. And I think that interventional does have some issues with lifestyle. I think that's 100% true. And sometimes I think about my decision from that perspective because of the fact that, so I had like a very challenging clinical cardiology fellowship. And when you were on call, which was quite frequently, you would get paged every 10 minutes. You would get paged all night long. And I'm sure that's true about many fellowships. And I think that for me, the main page that I didn't feel really angry about was the critically ill person, was the STEMI. Now, just because that was the one that made me the least mad doesn't mean that I wanted to take those pages for the rest of my life. It's a very good question. And the other thing that's true is that there are so few women that go into interventional. And I think that there's a very good reason for that. And it has to do with lifestyle. Maybe getting too personal, but I'm unmarried. Most women who go into interventional either do not have kids or had kids before they did interventional. Not all, but many. And I think that it's something that you really have to think about. And when I did tell attendings that I was planning to do interventional, I got a lot of snide comments from male attendings about how I should be prepared to never have kids, and that was the life that I chose. And so I think that it gets a little bit complicating choosing interventional. But what I told myself was, it's an extra year. I really enjoy doing it, but you have a clinical cardiology background. And to be honest, there are very few interventionalists who do pure interventional. A lot of us take clinic, a lot of us do general on the side. And so I did interventional with the plan that when I felt burnt out, I would be honest with myself and I would say, it's time to do general cardiology, or it's time to switch over to imaging. I have CT certification. There's a lot of remote imaging that you can do at different hospitals. And so I think that you just really have to be honest with what is good for you and also honest with when it's time to stop. And if you feel comfortable with that, then, I do, unfortunately, lifestyle makes a really big difference, and interventional does not have the best lifestyle. But luckily you can do other things outside of interventional too, if that makes sense.
Yeah, and I think that in fellowship, when you're working with your attendings that you become somewhat close with over the course of your years, it's a good chance to ask them, what their life is like, and to get a sense of them outside of that one interaction. I think when you work with me, let's say you imagine me always in the CCU, and that I'm always there 24/7, or if you work with Jess, that she's always in the EP lab. But I think all these jobs have a mix, right? So I think it's good to know, what are your attendings, A, work-life balance, and B, even work mix? Like, what are they in the CCU? How many weeks a month or how many weeks a year? What else are they doing? How are those demands? What are they afternoons and evenings like? So I think asking your attendings about their life is a good chance to see on the ground what different options might look like. And I think that people will be open with sharing with you, if you ask them, especially if you have a working relationship with them. I think for me, that was a helpful thing to learn. And even in a field that's sort of new, like critical care cardiology, where it looks different in different institutions, but what people are doing. So it's been helpful for me to ask around what people are, what their job looks like. And so to know that to empower you as you're looking for a job, as you're negotiating a job down the road, what's your ideal mix. So I'd say lean on your attendings and kind of get their full picture.
I love this question of, am I planning to, because I haven't started my real job yet. So, I did have thoughts about not working in my specialty. But actually, on the subject of work-life balance, another plug for EP. So my job that I'm starting in a couple of months, it's a 4 day a week job. And that's just what it is. And it's, normal business hours for medicine, at least. It's like 8 to 6, 4 days a week. I think I work 4 weekends a year. And that's a full-time job. But there is work-life balance, I think, and but I agree with Paul, and that's something that I looked for with my attendings. One of my attendings has 4 kids that he sees and is involved. He's like soccer coach and basketball coach. Another of my attendings has 2 kids under 3, and she's, and everyone's just, every single other female fellow at Cedars who was an EP fellow was pregnant during their fellowship, and it was very well supported. And so I think that it was good for me to see. I have a 2-year-old kid who I had right before I started EP fellowship, and everyone's been so supportive. And there were days I said, I need to go pick up my kid. I can't do this last case. And they said, that's fine, just go. We understand. And so I think there's also a culture in the subspecialties, um, and maybe I just got lucky with the group that I've been lucky to train with, but that was important for me. And in looking for a job, I wanted a job that would let me do a variety of things. I'm in the lab 3 days a week out of my 4, which is something I want. I want to be procedurally heavy, but also and I'm talking to the partners, and they said, we really encourage that you live your life. And that was important for me also. And so I think that I'm very excited. The question about 10 or 20 years, my husband has grand plans of us retiring in 15 years, which is crazy since we haven't even started working yet. But, short of that, I think I can see myself very happily still doing this in 10 or 20 years. Um, Less terrified, but still happy. So I think that sustainability is important because we trained for so long for this. And that's, I mean, then again, talk to me in a year or two and we'll see how it's going. But at least right now, it's something that I'm excited for the next big chunk of my life.
Yeah, just to build on a couple comments that were made, I think the sustainability is really important, and I think that can be it can impact your choice of specialty, but also I think to Nadia's point, even within each specialty choice, right, you have lots of choice about what your job looks like and how sustainable it is for you. So I think sometimes we can anchor onto the interventional versus EP versus heart failure, general cardiology, quick care. But within each of those, you can have such a different job, right? So I think there's still lots of freedom of choice after you make that choice for what your job looks like.
I think that's an excellent point. And to kind of jump off of that as well, it also depends on what practice you want to do, right? Which I think is one of the upcoming questions. Because, private practice versus academic versus semi-academic, either way, you can probably have, especially when you are at the negotiating table, you can have some negotiations, leeway on what you want to do, how much, if you want to do part-time, full-time, you want to do research, you want to have administrative time. I would say probably at the time of negotiation of your contract is probably when you really, or even before then, when you really should start thinking about what you want to delve further into, like research, like Paul is doing, and administrative work, fellowship work, so on and so forth. So also outside of the clinical practice, things that you should also consider as well.
All right, thank you so much. Yeah, it seems like work-life balance is very important in continuing the same specialty or switching to the, such as general cardiology and practice setting is also very important part to decide to be on the same, practice and same setting and quality of life. So yeah, so it'll be very, very helpful for us to, make a decision to, what kind of, career path we want to choose. All right, thank you so much. And then we can go to the next question.
All right. Our next question is, what skills should fellows start developing early if they're interested in your subspecialty? And how can fellows start preparing for the subspecialty? Either it could be experiences, exposures, or books, or what can we do?
I think I have a really atypical answer for that. So I th I think that when you think about procedural skill, some of it is learned, some of it does seem to be whether you have kind of good hands or not, right? So I kind of fell into this because I didn't fall into this, but I was kind of naturally good at doing procedures. So even during fellowship, a lot of the times other fellows would call me in for complicated lines or people who were bleeding a lot, people who were difficult sticks, and I would come in and do procedures overnight with other fellows. So it seemed more natural to go into interventional. Whether you have the ability to cultivate those skills, I think to an extent that's true that you have to have experience. But if you're at a good fellowship, your cath rotations are included. So I wouldn't say that I did extra rotations. In my opinion, being a good interventionalist is actually spending more time doing the other things because you might be able to do the STEMI, but what do you do when that person's in shock? So I actually spent a lot of my time focusing more on things like heart failure, on advanced support, on critical care, on the things that you would not just naturally get that exposure to all the time, on the imaging. Because to be a well-rounded interventionalist in that moment at 2 a.m., you might have backup, you might have someone to call, but it's you. So you should just know how to see and what to look for all of those things.
I agree with Nadia. Starting a procedural fellowship, it's it doesn't matter if you're starting from like here or here. The learning curve is like this, regardless. And so you get to you're going to learn so much about your procedural specialty that it's not like you're going to go practice doing ablations as a first or second year fellow. Like number one, they're not going to let you, but number two, it's just that doesn't really build enough to translate. Like you're going to do so much more in the start of a procedural specialty that you don't have to like practice those skills beforehand. General cardiology is a time to learn general cardiology, and so If you are doing that extra 1 or 2 years, you will learn a lot in that extra 1 or 2 years to prepare you. And so I personally scrubbed like less than 10 EP cases prior to starting EP, knowing the whole time that I was going to go into EP. I don't feel like it prepared me any more or less than any of my other co-fellows who have done more or less cases beforehand.
I think those are all excellent points. The one also thing that I would recommend is maintain a good, strong base in internal medicine, right? Because the heart doesn't just exist by itself. It's connected to the kidneys, the lungs, the brain, so on and so forth. So you never stop being an internal medicine doctor, and you should definitely know like other aspects of the body as well. So keep up the internal medicine knowledge.
I'll just give my 2 cents. I think for like echo imaging, it kind of depends like what you want to do. Because I think you could just not do an advanced imaging fellowship or advanced echo fellowship, like depending on your practice setting and how much you want to do of it. Like I think if you want to do like CT, MRI, nukes, like advanced echo, all that, like there's 2-year imaging fellowships. If you want to do kind of structural imaging in an academic center, there's 1-year fellowships. But if you want to kind of do TEs for tiers and kind of read a variety of studies in private practice, I think you can just get really good numbers in general fellowship as long as that's like offered where you are. Like I know some hyper academic places don't really offer level 3 as a general fellow. Some places do, but I think if that's something like you want to do as a general cardiologist, that I would just make sure that you've had adequate exposure, that like not only can you pass the boards typically like echo and nuke, and then I don't think you really have to, I don't know, Paul, you would know better, but you did CT boards, I think, but like I don't think you have to do MRI boards to read them, to read MRI, but just like make sure you have enough numbers that you feel comfortable in your specialty. But if you want to kind of really focus in on something, I would try to get some amount of exposure um, as a general fellow if you're thinking of doing an advanced fellowship. Um, yeah.
Yeah, I think not much to add about all those great tips about, readying you to sort of take on that field and to become an expert in your subspecialty. I think another sort of practical thing that it can be helpful is during general fellowship to take on some sort of project with a mentor in that field, whether it's a research project, education project, QI. I think just that on the one side, it sort of gets you thinking about that field in a way that it gets you some more exposure to a certain deep dive on a topic, and then also just builds that mentoring relationship that each of these, cardiology is already a small world, and that each of these subfields are even smaller worlds. So I feel like it helps you as you're thinking about those next steps and fellowship and job to sort of start to nurture some of those connections.
That's all very helpful. Thank you so much. It sounds like getting exposure early on and mentorship is key. So we will jump on to our next question.
Okay, so next question, it would be, what is the one thing that you wish you had known before entering your subspecialty?
I have a really good answer for that. The job market. So I think it's a little bit better now, but interventional and especially structural has had a little bit of a tight job market. And I knew that about structural, and it's actually one of the main reasons I didn't do a structural year. But I actually had no idea that interventional was kind of a difficult job market. And I came out of fellowship pretty soon after COVID, and it was pretty bad at that time. So I actually had an extreme amount of difficulty finding a job. And so much so that, being very honest, it has made me question my decision to go into interventional purely because of my difficulty finding a job. And so we'd like to think that that doesn't make a difference, but it does. I'm from the Northeast and I live in Stockton, California because I couldn't find a job. So I think that that is something to think about. It's always something to think about.
I think that's a really good point. And I would just say, like, even for like imaging in general is very common, but I was looking for like a very specific structural imaging role, and that is less common and is actually very poorly reimbursed. And so you kind of need to be in a salaried setting because if you're in an RVU setting, it's really not going to work out for you. Um, and so that, was a consideration when I was looking at jobs and like what kind of job I was going to take. Um, but I do think just thinking about like what type of job you want and if you know you're going to be really limited by geography, like I'm not, but I know people who know like regardless they need to be in a certain area, like you might want to do something that is more flexible and more common. Whereas if you kind of know you have a passion, you're willing to pursue it and live wherever, um, that's awesome. I think it just like, that is something to consider of like how common the type of job is that you would want and if that's like important for you.
Yeah, I agree with those excellent points. And, job opportunities can be variable, especially in heart failure and transplant. And also, I think when fellows are looking at jobs in the heart failure and transplant standpoint, I think really thinking of where they want to end up, like a private practice where you have a lot of heart failure, bread and butter, mechanical support, shock, but maybe no transplant, or you really want that transplant job. And regardless if you have to end up across the country, is that really what you want to do? So I think thinking about that and maybe exploring that before you enter the heart failure and transplant field is something to really, really consider. The other thing that I think is relatively unknown about the heart failure transplant field that I didn't know going into it is how many like different subsects there are of heart failure. So there's like amyloid, there's no cardio-oncology, there's cardio-OB, which often falls under heart failure too. And so that kind of goes back to the jobs. Like you can really flesh out your own little niche and make it your own, right? And so that can mean that you can end up in like an academic institution doing like the only person doing cardio OB or, hypertrophic cardiomyopathy. But that has a lot of planning, a lot of like forethought in order to consider that, and also a lot of exposure and education. So I guess that's one thing I didn't know about heart failure.
I think one thing I suspected, but didn't really hit me is so I had taken time off to do a research year. I was very excited about having a research career. Um, and then now that I've spent 2 years in 100% clinical fellowship and I really love doing procedures, it sort of made me face the reality that I, at least for me, don't think it's possible to have like a healthy research career where I'm submitting NIH grants and be procedurally proficient. And so I had to really take a hard look at my life and what I wanted and kind of choose essentially. And so I'm lucky in that my job has told me that they want to start entering clinical research. They're encouraging me, and that's something that's open for me to pursue. Whether what that looks like, I don't know yet because we'll see how it goes when I get there. But something that they were excited about with me. But I thought that I would be writing grants to the NIH and also, doing FPVT ablations. Like none of that is actually what I want to do, and I'm realizing. But it's something that, you spend your whole training doing research either because you like it or because you feel like you have to. And then at some point you realize that you don't have to anymore. And I wanted to, but it's not what I want to do the most. And so I think thinking about what you really want out of your career, because you don't have to do all these things to tick boxes anymore, and you maybe can't do all the things that you'd like to do. And so I think I knew that, but I didn't really understand that until it sort of came time to think about what I wanted my career to look like.
Right. Thank you so much. Yeah, it sounds like a job market and job opportunities and research setting would be very, affecting these questions. And it would be really great if we could talk a little bit more about the practice model, where you work and how they decided to academics versus the private practice. That would be very helpful.
I think I'm the only private practice doctor. And to be honest, I wanted to do something more academic. So I think that it's a very interesting decision, and academic versus private practice are very, very different settings. And as I was kind of saying before, I had quite a bit of trouble finding a job. I have I would say, the least niche job out of everyone else who's speaking today. And so what I had specifically been looking for was a salaried, mostly interventional job because I really like doing procedures. And there are so many different types of jobs when you're looking, and there are just so many different ways. There's just such a big spectrum. And in the end, the way that I had to compromise to find myself a good job was I did go into private practice and I do a lot of general cardiology clinic. And so I think that there are pros and cons to that. I think that, to be honest, I think that in private practice, you have the opportunity to make a lot more money. You have a lot more flexibility in your own schedule to an extent. You supposedly kind of get to say what your practice looks like more. But I do think that because what you essentially do is, in order to pay for yourself, you see more and more patients, you get less time with each patient. And so I think it really depends on what your goal is and also what the environment is like. And the reason I say that is because one of the main reasons I went to Stockton was because of the way the private practices were set up. So most of Stockton, all of Stockton is private practice, which means that, in the Northeast where I trained, if you were private practice, all of the hospitals had salaried interventional cardiologists. And if you were a private practice interventionalist, you had to beg for a spot in the lab. And the fellows, me, when I worked with one of those attendings, I knew I had to watch them very closely because they were more likely to be highly unskilled. And very often you were acting almost as their attending, is how it felt like. And so I came to Stockton because everyone here is private practice. And what that means is that most of your cardiologists are interventionalists. We all take call. I think it's a very high skill set, and we all share dedicated lab time. So we're not competing with in-house doctors for lab time. So I think that the reality is that you will be surprised where you find opportunities that line up with what you want. And I wanted something academic. And then like I said, I wound up in a private practice, but that worked a lot better for me than some of the more academic opportunities I was offered, where I was kind of being boxed out of the lab, so to speak. So the job search can be really interesting, and it's important to look broadly. And it's also really important to have connections because I was essentially at a community hospital where I did my training, and I didn't get any help looking for a job. And I think that that's actually why I had a lot of trouble finding a more academic job. So I think I got a little bit off track, but it is very interesting when you search for jobs because every job will be different. And when you talk to a recruiter, they say, well, what are you looking for? And my response to them was usually, what do you have? Because you don't want to limit what you're hearing about, because each job really does sound very different in certain ways.
So when I was looking for jobs, I think one thing I'll add is that I was kind of surprised because in my mind there was like a delineation. There is academic practice and then there is private practice. And academic practice comes with things like trainees and research, and private practice is none of that. And so when I was looking, I was actually surprised that a lot of the private practice, quote, just not university affiliated, can offer a lot of these things. So one of the things I mentioned is that a lot of more and more private practice groups are engaging in research. The private group I'm joining, it's a large hospital group. They're participating in clinical trials. They're trying to do clinical research. They have a large patient database. They have a medicine residency. They're starting a cardiology fellowship. And so a lot of the things that I thought I was going to give up by not staying in academics are options. And so I think that it's something to consider is that you we're all, brought up in academic places because that's where you train. But if there's something that you're looking for, it doesn't necessarily have to be in a university setting. A lot of the times you can find teaching or research opportunities in other practice settings. And then, as Nadia mentioned, the compensation in a private practice, it's vastly different, especially for procedural specialties. And then things like lab time, again, you're going to get more if you're not in an academic setting. Um, and so I think there are some things to be considered, but it was interesting to me that there are, a lot of crossover in the things that you can find in both places.
I'll just comment quickly and then I think I'm gonna have to hop off. Sorry, guys. But I interviewed pretty broadly, like both in private practice and in academics, which is where I ended up. And for me, like wanting to do some time doing TEs for structural procedures, like it just didn't, it's hard in the private practice setting just because like your number of RVUs per TEE is the same, whether it's like a MitraClip taking a couple hours or an appendage that takes 10 minutes. And so that I think was something like I wanted to pursue and I'm happy that I am, but like is a consideration if you're not in a salaried model. Um, and I also, like working with trainees. I do think in the private practice setting, I'd really be like pretty much fully a general cardiologist, which I love and, mostly am now, but was also, and especially in this phase of life, like having a young kid and building a family, like was happy not to take call. Like I take home call 4 weeks a year and never have to go into the emergency room and work like 4 weekends a year, except for reading some echo. So I do think that piece was nice in addition to like the teaching and all that. I'm not really doing any research despite being in an academic setting. But yeah, I do think some of those kind of considerations like how are you reimbursed for what you do? What does it make sense? Like because like I could go make more money as a general cardiologist in private practice. But like what does it make sense for your interest in like life phase at the time? And kind of you can always switch between them too. Like people leave academics all the time. We have plenty of people at UCSF who like came from private practice, who are clinicians, who are now like working on research projects and teaching, who came from private practice. So I also don't think it's like a you pick one forever type of situation.
So I
Yeah,
think that, oh, sorry.
Yeah, go ahead, Dr. Sheikh.
Oh, so I was going to say that to Allison's point, which is a very good point, something to think about with private practice really is reimbursement. So you do not get reimbursed well, not just for imaging, but for any procedures. So the reality is that you will make way more money in a private setting, seeing patients in a clinic than doing procedures. So for one cath that I do, a diagnostic cath, however much money I make, which to be honest is not that much, is probably a couple $100s or so if it's diagnostic. You could see 8 patients in the clinic and make that much money per patient. So the reality is that when you are in private practice, you do the procedures for the passion of what you enjoy doing. And the pressure is actually on you to minimize procedures and see more patients in the clinic. If somebody is interested in going into private practice, it should be someone who really enjoys the clinical setting, somebody who really enjoys general cardiology, and you also have a passion for doing those procedures if you're procedural. Because again, the reality is that you make more money seeing patients. So if your goal is to kind of be in that setting, it's not sustainable if you're planning to just do procedures unless you are linked up to a large group where you are like the interventionalist serving 8 general cardiologists, for instance. And again, that's why our practice model in this area works, is because everyone here is an interventionalist and everyone here has their one day in the lab. But realistically, they make 20% less money than they would have because 1 out of 5 days they're in the lab instead of seeing a ton of patients. Now, there are hybrid types of jobs, which are more RVU based, where private practices are linked to large hospital groups, and then they get paid RVU. And those positions do allow you to do more procedures and still make money in a private practice range versus a salaried interventional position at a hospital. But again, it's completely a spectrum, and you really have to listen to the jobs descriptions to find the balance that you like, because each job is going to have a slightly different balance. But it is important to realize that the reality is that we think of surgical or procedural specialties as paying a lot of money for procedures, but your interventional procedures, at least EP procedures, I don't know, they might pay more, but interventional procedures, I would say, are not huge money bringers. Your diagnostic procedures are not, and then your complex procedures are actually you might make more money on them, but those are usually much longer. And therefore, again, it's kind of the patient balance. So that's just something to think about for people who are interested in considering private practice.
Um, just to add to all those excellent points that have been made. So, definitely reimbursement and figuring out what type of reimbursement they have, whether it's just pure RVUs or salaried, is going to be very important. When I was doing the job search, I actually created a checklist of everything that I wanted and would just go through like the interviews and like check off. I would like, yes, working with fellows, love it. Yes, education, yes, research, yes, complex cases, yes. But what ultimately it came down to towards the end was during like the interview period or even the pre-interview or post-interview period, how I felt about those people that I was interviewing with. Was it the perfect job that I was really looking for? But like everyone looked like they were super miserable, or they looked like they were at each other's throats, or like completely unhappy. That's ultimately what it came down to, is like, how did I see myself fitting in that particular field? I'm sorry, in that particular institution? And could I really, work with those people long term? And so those are kind of things to really keep in mind on top of all of the excellent points that were already made.
Yeah, and just to add, I think you heard I think the importance of sort of evaluating the job in front of you as opposed to these big categories because there are lots of things on the spectrum. We heard about some jobs that, while they're private practice, have more academic flavor, have more research and teaching. But it also just if it goes the other way too, that plenty of academic institutions, jobs that may sound to you as purely academic, actually have an RVU-based model or have a workflow or day-to-day, week-to-week work that feels a lot more like a pure clinical private practice cardiologist. So you can see that on both sides of the spectrum that you may think it's a full academic job, but it may look more like a pure clinical job, especially as these big hospital centers are looking to expand their clinical volume. So I think good to evaluate the job in front of you and not just be yeah, kind of be open to. I like Nadia's idea of tell me what you got. Don't tell me everything. Don't let me limit you which jobs I'm going to hear about. Um, and I think one thing just thinking about as you think about your job. I think it's helpful to have an idea in your mind of what you want your ideal day, week, month to look like, because there's sort of a balance when you start early on in your job. On the one hand, you want to be, to some extent, the yes person and the person people are coming to, especially if you're new in a place, you're new in a job. You want to take on opportunity and see what sticks and see what you can build off on. On the other hand, you also don't want sort of everything to sort of fall to you and to be taking on too many responsibilities and not able to focus on what you actually want to do. And so I think it's helpful to have a clear picture in mind as you start your job of what you want, ideally, your time to look like in your job. And that way you can sort of build and choose which opportunities to take advantage of.
All right. Thank you so much, everyone. And we had a very great discussion. And thank you so much for sharing your, experiences and your, good, recommendations and all. And it will be very helpful for us to, help out and, forming our future careers. Thank you so much for joining us and sharing your expertise.
Yeah, we really appreciate you taking your time, especially, during the week to really impart wisdom to us as we're trying to figure out what career path to take. And I know, this video will many people will watch it and benefit from it too. So we thank you.